Nice to meet you, Dr. Barlow.
Yeah.
It's a very great honor to visit here and meet you. Actually, it's a great experience for me actually, and especially I had very good chance to learn about shoulder and elbow. You know, it's in Mayo Clinic. This hospital is the toughest hospital in America, and you are also the toughest surgeon in orthopedic. So I'm very impressed. I learned about many things about the orthopedic, but I also learned about your attitude to the patient or your teammate. So it was very awesome. So how can you keep yourself so cool to every people?
Well, it's a great question, and thanks Korean friends and Korean orthopedic surgeons, and thanks for visiting. It's my honor to have you here. And I think what I would say is the important thing to me is that we spend a lot of our grown lives, we spend some of it with our families, but we spend a lot of it at work. So I think it's important to have love for our patients, our work staff, and our work families, because we spend so much time working together that I think that's really important to me. So I really enjoy in clinic getting to know my patients, understanding them a little bit, what they want, and that's kind of the fun part, in addition to obviously making the diagnosis and choosing things like that. And then at work, I think to be surrounded by people who enjoy shoulder surgery, my team, my surgical assistants, and my scrub techs, I think we all are passionate about shoulder surgery, and we really like to do it, and we like to be together, and we like to do cases. So I think that's fun, and it's a little bit contagious. The hard part is when you have complicated cases and difficult things to do, you know, how do you stay cool under pressure? And I think most of that is just repetition, training, repetition, and trusting the training that you have. So one of the defining characteristics of Mayo Clinic here is a collaborative approach. So Dr. Sperling and Dr. Sanchez-Sotelo, who are, you know, substantially older and well-known than me, and certainly have a lot more experience than me. I run every clinic day, just about, I run a case or two by Dr. Sperling. So I walk down the hall and I say, you know, what do you think? So then you're combining my experience with his experience, with Joaquin's experience, and Mark Mori. And through that, I think you build the confidence of other people that you know, I'm not doing this alone, and I'm not the only person making some decision when I don't really know what's going on. So you accumulate all of your training from your residency and your fellowship, and then you add on your personal experience of what you've seen and what works for you, and then you mix in sort of the literature and what you read about, and I think that you can build a platform that feels strong over time, that you can say, I know that I'm doing the absolute best that I can for this person, and we don't have control over how a patient does necessarily after surgery, but we have perfect control over how we talk to them, what decision we make about what implants to use, how we place the implants, what we're willing to accept. So we control all the things that we have control over, and then the rest is in God's hands, and we hope that it works together. So I think mostly it's focusing on the things that you can have control over, asking questions of people around you, trying to probe the literature, not for the answer you want, but the answer that the literature wants to give you, and then you can feel more confident going forward.
Thank you. Also, you are absolutely handsome. That is the you know, the most handsome doctor in I think that is the reason to be a cool state.
I don't know about that, so it's really fun to get to interact with lots of people and get to learn about them and take care of them.
Anyway, I'm very impressed because you are always being nice to your mate or the patient. So I feel that you have this very good heart, and you have very good confession to patient. That could be a very great basic to be a much more progression for your future. So in case of the shoulder surgeon in Korea, there's a lot of the junior orthopedic surgeon. There's a lot of the controversial in case of the irreparable basic tear. So what is your opinion? There's a lot of the opinion, but what is your prefer to treat elderly people who have irreparable?
I did a visiting fellowship, a traveling fellowship in Europe in the fall. And one of the big questions that I wanted to answer for myself and my patients was how best to treat the irreparable rotator cuff tear. And I think the answer is not set in stone. I think it requires a little bit of a nuanced approach depending on the patient. So my algorithm for the most part is, for the young patient, let's say posterior superior rotator cuff tear, supraspinatus, and then maybe some subscapularis infraspinatus. In almost all cases, I'll attempt to repair. And basically repair the a lot of it the way that Steve Burkhart taught us. Repair the subscapularis, repair the infraspinatus. If I can't get the entire rotator cuff over, then I'll do a superior capsule reconstruction. And that algorithm would be the same probably for a revision in somebody between 40 and 60. So under 60, I would even try a revision with a superior capsule reconstruction. So subscap repair, infra repair, dermal allograft is what we use in the United States, and then repairing the remnant infraspinatus, or the infraspinatus that's repaired to the graft. And that's kind of my first go-to. That operation is one that is a little bit technical. It takes a long time. It's a long recovery and rehab. So I continue to keep that in a place of I don't know the future of this, but Dr. Mihata's data is good and others' data are good. They've looked at my series at Ohio State when I was there for 3 years, and then now my series at Mayo Clinic. And in both series, there's a 10 to 20% revision rate. It's very low. Outcome scores are good, forward elevation is good, and pain scores are very low. So I think it continues to hold a place for me in my practice. If they get a little bit older, let's change that. The one group that I do lower trapezius transfer is mostly infraspinatus atrophy, so isolated infraspinatus atrophy. Those are probably usually muscle tendon junction tears of the infraspinatus that get missed. But the supraspinatus looks fixable, so really more posterior tears. Those I think I'll do a lower trapezius transfer for. But I don't do lower trapezius for the supraspinatus. I think it's helpful for infraspinatus, but not for the supraspinatus. And then as they get older, let's say over 60, evidence of rotator cuff tear arthropathy, so arthritic change, high riding of the humeral head, and in particular if they have pseudoparalysis, that's not acute, chronic pseudoparalysis, then I will think more about reverse total shoulder replacement. Older patient, high riding, a little arthritis, and pseudoparalysis, those are kind of the factors. And especially in patients over 60 who've had a previous repair, I'm less likely to do another repair in SCR. Most of those patients, you know, you talked about, I think I spend a lot of time explaining to the patient what the options are. And when you're 63 and you've had a previous rotator cuff repair and you have a massive tear, I don't think we know what the right answer is. So I'll talk to them about reverse and talk to them about SCR, and I'll mostly let them choose between those two. And if they want the SCR and in a year I have to do a reverse, they're not upset because they've made that choice and we've taken that path together. So for me, it's mostly SCR and then reverse, and it's just those kind of nuanced decisions that push me one way or the other.
Yes, thank you for your great opinion. Your opinion might be take a lot of the time with a lot of the experience or a lot of the paper, you know, and a lot of the discussion. So I think we have to sharing with a lot of the doctors in the world. So if we discuss only in the conference, it is only the paper. It takes a lot of the time, you know, to publish it. So I want some days I think somebody makes some application like a Facebook. We can talk about the case with all people or doctors. If then we can sharing faster than before. I think the last question is that, as you said, we have to reading another progression for the future. Do you have something to talk about to junior staff, junior doctor about how to progress by themselves? Is that your tip for that?
Yeah, I think that the key, one of the terms that we talk about is rage to master. So this desire to keep getting better, and I think that's review of the literature. I think that's educational opportunities, even traveling to find educational opportunities to grow your knowledge, reviewing your own x-rays and your own patients and being very thoughtful about that, and then talking to your partners about their opinion.
Right.
Sometimes we get an idea and we think this is just how I do it and it's the only way to do it. And oftentimes we don't even actually want to share or talk to other people because we don't want to be convinced that we have to do something that's difficult or hard for us.
Right.
But I think we have to have a humility about our orthopedic surgery to say, I'm not there yet. The field will continue to advance. And I don't think you need to be a cowboy and be the first person to do everything.
Yeah.
But as you demonstrate in your practice, well, I'm having some problems with this and I'm reading about this technique, go to the cadaver lab, go visit the surgeons, find out how they do it, see if it makes sense to you, and then try it and build your practice.
Right.
And I think that oftentimes we say, well, I didn't learn that in my residency or fellowship. I'm not going to learn that. I'm too nervous about it.
Right.
You will do the wrong thing because we have to continue to learn and evolve.
Yeah.
Many of the things that people learn in their residency or fellowship are obsolete by the time they're 5 or 10 years out.
Right.
So the reverse total shoulder placement was medialized glenoid, medialized humerus for a long time.
Yeah.
Now we're lateralizing, and I think that the answer will be lateralization. But if everybody says I only learned it one way, or before that people only did hemiarthroplasty.
Yeah.
If all we did was hemiarthroplasty, we would be hurting patients.
Yeah.
That would hurt people. Now we know. So I think it's that kind of iterative response of being able to be humble, say it's okay that I changed my mind about this, I was wrong before, and now I do this, and recognize that. It's hard for us as surgeons, but I think that desire to keep getting a little bit better, especially for the young surgeons who have some skill set but don't know exactly what their boundaries are. And I think that's critically important. And obviously, you're traveling, it's a really great opportunity to come see how a different part of the world treats shoulder problems. But there's lots of different opinions, each of which have some value. So those are the ways that you kind of build yourself. It's a mosaic, it's little bits of different people that you see and put together through your life, and then that's who you are at the end. And I think we shouldn't be ashamed of that. We should be proud of that we take little bits from different people.
Yeah, thank you. So that is the reason why I have my small clinic, but I want to expand to the network in the Korea. That is because a lot of the young doctors in Korea or another world, we have to share our opinion and another country. That is very important thing. It's great honor to visit meet you.
Yes.
Dr. Barlow.
It was great to meet you too, and you're all welcome to come to Mayo Clinic. So we love it at Mayo Clinic. We think it's a great place, but you can make little Mayo Clinics all across Korea. So the surgeon is the method. So you have the opportunity to take this back.
Yeah, thank you. It's also the great educational system was fantastic for me. It's very awesome. So
good.
MB system. Anyway, this video will be a first video maybe in Mayo Clinic. There is no information about Mayo actually in Korea. So it could be, I hope this video could be helpful to another surgeon or in another world in Korea especially.
That's great.
Thanks so much.
Thank you.